So actually it's very clear that the TINTIN technique, as it is called, the combination of a luminaire with an evolution stent, is specifically for the more complex femoropopliteal lesions. Why? Because first of all, the simple lesions, most of the time we can handle it with just a drug-coated balloon without scaffolding. On the other hand, if we have very long lesions, we know that we need to have a scaffold. If we are just using a bare metal stent, we know that we can do better in terms of patency and durability. So in my opinion, especially in these more complex lesions, the combination of both the drug elution by the balloon combined with a good scaffolding is the way to go, and that's the so-called TINTIN technique. So of course it's a nice theory to state this TINTIN technique, but it needs to be based on evidence, of course. And today I'm very happy and proud to have this evidence in the TINTIN trial, of course. And we're going to present here at Link today the 5-year results, also with some sub-cohorts of this TINTIN trial, specifically in the lesions that I've mentioned before, long complex lesions. We are talking in the TINTIN trial, for instance, about lesions 24 centimeter in length. We are talking about 60% chronic total occlusions. We are talking about moderately to severely calcified lesions. So and we notice that the outcome there, on the longer run, we knew already for 1 and 2 years follow-up, but now up to 5 years follow-up, we know that the freedom from TLR, for instance, is more than 60%. So it means that after 5 years in lesions with 24 centimeter heavily calcified, only 4 out of 10 needs to have a reintervention after this long time. So for me, this is the ultimate evidence to prove that this technique is safe and durable. The combination of both devices, the luminaire DCB and the evolution stent, was for me actually a no-brainer. We had already sufficient data with these devices. On one hand, we have the FPAC trial, the randomized controlled trial, showing the superiority of the luminaire versus a plain old balloon angioplasty in rather simple lesions, quite normal for these randomized controlled trials. On the other hand, we had the evidence already with the evolution trial, with the evolution stent, lesions around 10 to 12 centimeter, and also there we noticed the efficacy and the safety of the evolution. So for me, combining both in one technique was actually a no-brainer. The most important thing for me is even before you are doing the drug-coated balloon treatment, you need to do a good vessel prep. And the vessel prep is based on how you are passing the lesion, how much it is calcified, and so on. And so different methods of prepping techniques are available today. In the TINTIN trial, we just did the plain old balloon angioplasty. Then afterwards, I recommend to do first the DCB treatment, and then finally to end up with a nice scaffolding. Some people, they try to do it vice versa, but unfortunately at that moment when you are implanting first your scaffold and afterwards you post-dilate with a DCB, you miss some important percentage of the paclitaxel elution to the vessel wall on the struts of the stent.